Welcome to the Bristol Poverty Institute Conference, Poverty and the Sustainable Development Goals from the Local to the Global, Session 2 this afternoon, taking over from where we left off this morning when we were remarking on the gross inequities in child deprivation indices across Europe. It leads us nicely into this first part of the child health session. My name is Matthew Ellis. I'm a senior lecturer in global child health here at the University of Bristol. And my co-chair, Dr. Maya Coley-Lynch, who will be taking over later on, is an academic paediatric fellow here in Bristol also. Few words of housekeeping. This is being recorded and posted on our Bristol Poverty Institute YouTube platform and embedded in the website. By attending, you are consenting to be part of this recording. Please ensure your name is on the Zoom Q&A chat list as opposed to guest, so that we'll be able to introduce your questions. You'll be able to ask questions using the Zoom chat function found at the bottom of the screen. We'll do our best to fit in all the questions we can. We'll be taking the questions after each speaker this afternoon, of which we have 3. 2 before the tea break and once after. As always, please be respectful. All events at this conference are being monitored and we reserve the right to remove attendees whose comments are deemed offensive or derogatory. Good. So I'd like to introduce our first speaker, who is Karen Lute, Professor Karen Lute here at the University of Bristol. Karen read medicine in South Africa and specialised in paediatrics here in the UK. She has a clinical neonatal medicine role and as an academic is the lead for the Child Mortality Analysis Unit based here in Bristol Medical School, which has lead role for England's National Child Mortality Database. We're lucky to have Karen abstracting some of the key findings from the latest report, and which remains under embargo. So she will be talking around the findings and helping us to understand the pattern of inequalities in child deaths. Thank you, Karen.
Thank you very much, Matthew. And thank you for the invitation from the BPI to speak today. I'm just going to share my screen. Hopefully that's visible for everybody. Great. So as Matthew said there, I'm the National Programme Lead for the National Child Mortality Database, or the NCMD, as we call it. The NCMD is commissioned by HQIP on behalf of NHS England, and this database is the first of its kind globally, led by the University of Bristol in collaboration with partners. And we started collecting data on April 2019. The partners are HQIP, UCL Partners, University of Oxford, QES, the software company, and then very importantly, 3 charities, bereavement charities, SANS, the Stillbirth and Neonatal Death Charity, the Lullaby Trust, and Child Bereavement UK. And these 3 charities are actually on our project team, very much closely involved with how we operate. The aim of the NCMD is to collate, analyse, and to ensure that deaths are learned from at national level and that this learning is widely shared, and that the actions are taken locally and nationally to reduce the number of children who die. So that's ultimately our mission, is to reduce child mortality. As you probably know, the Global Burden of Disease study published in 2019 in The Lancet showed that the UK has the second highest child mortality rates in the under fives in Western Europe, the second highest after Malta. So child death reviews, which forms the basis for the data that we collect, child death overview panels are tasked with reviewing deaths of all children residents in their area in England. And this falls under the Children Act, so there's a legal responsibility to do this, and also to notify all deaths to the National Child Mortality Database within 48 hours. So there's the notification process, first of all. And then following this, there's a comprehensive multi-agency information gathering process carried out, and a formal review of the child, a child mortality review is then done using the statutory forms, and it includes the views of the families. And this review is then ratified, checked over by the Child Death Overview Panel, which is multi-agency as well. So that's what makes this process so unique. This is not just collecting demographics, it's also looking at a comprehensive review of the child's circumstances and the care that they received. So the data is analysed in two ways, briefly. The real-time surveillance and analysis of review data, which the real-time surveillance is using the notification data that we collect within the 48 hours of the death occurring. This has been incredibly helpful during the pandemic, because we've been able to monitor child mortality in real time. I think the only country in the world that's been able to do that. And interestingly, the mortality, the deprivation indices on average of children dying haven't changed. And then we've also, the analysis of the review data includes the full data set after review by the Child Death Overview Panel, which is often not available for many months after the death, particularly in cases that are referred to the coroner. But of course, that's where the richness of the data lies, is in the fully reviewed data set. And I'll show you some data that comes out of there. So when we talk about social deprivation, the metric we use in the NCMD is the index of multiple deprivation for England. We use the 2019 data, which basically splits the country into 10 centiles. And this measures relative deprivation in an area that is suitable for use when deprivation is concentrated in small areas. And the domains include income, employment, education, health, crime, housing, and living environment. And it's basically, it's built on the postcode, so the area that the child lives in. This is just a table to show you. It's taken from the ONS data, and it shows you the deprivation deciles 1 to 10, 10 being most deprived, 1 being least deprived, and the child population living in that centile. So what you will see very quickly when you go across this is that there are many more children living in the most deprived areas, so that the population density there is higher. And of course, that means when you're counting events such as death by decile, you do need to adjust for these numbers, because there are more children in the more deprived areas. So this thematic report on child mortality and social deprivation will be published shortly. As Matthew said, it's currently under embargo. This data comes out of the National Child Mortality Database, analysed, and then we've also worked with Child Poverty Action Group as a partner on this on this report. If you want to find out as soon as the report is published, if you want to go to our website in the contact section and register your email, then you will receive the report as soon as it's published. The key objectives for this report were to find out the association between the risk of death and the level of deprivation for children who died in England between April 2019 and March 2020. so 1 year. And that's actually just before the pandemic had its effect, so ending end of March 2020. To look at the association between the risk of death and the level of deprivation by category of cause of death. So not just deaths overall, but also the category of cause of death. To calculate the population attributable risk fraction for deprivation with respect to child mortality. Also to look at the effect of deprivation on the proportion of deaths with identified modifiable contributory factors. And also to showcase some exemplar projects highlighting how child death overview panels had developed local strategies informed by their recurring review themes and local learning to reduce infant mortality. And particularly the Manchester CDOP had a really brilliant project, a 5-year plan focused on infant mortality. So the methodology we've used, as I've said, we're using the data April 19 to March 20. There are 2 cohorts in this report. The first is the reported deaths, so the notifications within 48 hours. And of course, that gives you your complete denominator for child mortality in England because there are no opt-outs. And then the second cohort are the cases that were reviewed in that time period. So these children, many of them will have died in years before. But of course, that's where the richness of the data lies. And we've described these cohorts by age of death, less than a year, 1 to 4 years, 5 to 9, 10 to 14, and 15 to 17 years. The NCMD collects data up to the 18th birthday by sex, area of residence, urban or rural, ethnicity. And our data is virtually complete for ethnicity, which is far better than what ONS, for instance, manages. And also the category of death and modifiable factors measured by deprivation deciles. So the cohort is actually described the demographics in this report, which has already been published. If you want to go and have a look at it, the link is below. So this is the CDR Child Death Review data 2019-20. And I'm just going to show you some highlights about the demographics. So if we look at the deaths reported in that period by the numbers, overall there were 3,347 deaths during this period from 0 to 18 years. And this is by region of reviewed cases, and you will see London has the highest. Of course, this has to do with where the majority of children also live. So this hasn't been corrected for population. And if we look at the number of reviewed deaths in 2019-20, 2,738 deaths were reviewed by child death overview panels, and that's the data that we've collected. This also gives you an idea about number of reviews by year. So going back to 2015-16, you'll notice that there's a slight drop off in the cases reviewed, and that's because the arrangements for child death review changed during this year, when actually this moved from Department of Education to Department of Health and Social Care, and the process changed. And of course, the first couple of months were also affected by the pandemic, so that's why there were fewer children reviewed in this period. This gives you an idea of the age spread. So what you'll notice, the vast majority of children who die are below 28 days, so they're neonates. And then it goes down to 15 to 17-year-olds, increasing slightly above the 10 to 14-year-old cohort. The dark blue is where we have reviews that have identified modifiable factors. So you can see that here you can see the burden of modifiable factors is highest actually in the under 1, so in the infant mortality group. And then the place of death for the majority of children is actually hospital. More than half of children die in hospitals, and then also at home or in private residences next. Hospice is relatively low. And what this means is in hospitals, the majority of children who die in this country actually die on neonatal units. So that's That's interesting. And about 30% of children die in children's hospitals and in pediatric intensive care units. This is a complex table, but what it shows you is, if you just look at the top line, these are the categories of cause of death, and then the bottom line, the totals, just gives you an idea about the numbers. So what you can see is perinatal, neonatal events, 851 children reviewed. So that's the most common cause. Chromosomal, genetic and congenital anomalies, 674, second largest. And then we have a few groups of causes that are around the same 10% mark of total child mortality. So that's sudden, unexpected, unexplained deaths, infection, chronic medical conditions, acute medical conditions, malignancy. Fortunately, deliberately inflicted injury, abuse or neglect is not that many, 60 children per year. So not a massive amount of children, but nevertheless, each one of these deaths is a complete tragedy. And the same with suicide or self-inflicted harm and trauma. And then if we look at these categories of cause of death and look at the modifiable factors as a percentage of all the modifiable factors, what you will notice is that a few stand out. So with inflicted injury, abuse or neglect, almost 3/4 are identified with a modifiable factor. And the same for trauma or external factors and sudden, unexpected, unexplained deaths. And then the malignancy, relatively very few, 5%, and perinatal, neonatal events and infection around 1/3. But you can see when you start targeting these modifiable factors to reduce mortality, I mean, that is really where, you know, the holy grail is in terms of reducing future deaths. So in this report, we worked out the population attributable risk fraction. Unfortunately, I can't give you the actual number for this because that's under embargo at the moment. But this was sufficiently important that, you know, this report was placed under embargo, is what I would say. And this is basically looking at comparing the risk of death in the most deprived 5 deciles versus the least deprived 5 deciles. So effectively thinking about if we were to have, you know, the poorest half of the country would have the same mortality risk as the richest part of the country, what would we achieve in England? Now, if we look at the contributory factors that the CDOPs categorize, there are 4 domains: factors intrinsic to the child, factors in the social environment, factors in the physical environment, and factors in service provision or service delivery. And in each of these, we look at the following, you know, CDOPs look at the following factors. So the factors relating to the child, it's the child's age, gender, ethnicity, pre-existing medical conditions, developmental or behavioral issues or disability, and for neonatal deaths, the mother's health and well-being. And if you think about, you know, 2/3 of child deaths are under 1, this area of the mother's health and well-being is incredibly important, and also maternal nutrition. So these are all areas that we need to focus on. In the social factors and social environment, which includes the family and parenting capacity, we're looking at family structure and functioning and wider family health issues, provision of basic care, engagement with health services, including antenatal care, employment and income, social integration and support, and the nursery, preschool or school environment. And some of the categories of death, for instance, where we look at inflicted injury, etc., and sudden unexplained death, so the SUDICs, as we call the cause of death, these factors in social environments dominate. And the other area where this also dominates is factors in the physical environment. So this is where we're looking at poor quality housing, overcrowding, environmental conditions, home or neighbourhood safety, that contribute to common childhood injuries, and the mother's environment during pregnancy. these factors also dominate in many of these child deaths. And then service provision, I'm not going to go through this whole long list, but remember, this is service provision not just through health, but also from social care, education and other agencies. And for hospital deaths, these factors tend to dominate, but for deaths outside of hospital, the other three do. So I've spoken about modifiable factors. What are those? Well, in the first instance, the definition is where these contributory factors that I've gone through in the last 4 slides, if these factors contributing to death are defined as modifiable, so that means by means of nationally or locally achievable interventions, they could be modified to reduce the risk of future child deaths. So this is where the rich data lies. So if a CDOP has categorized a death as modifiable, they then go ahead and say what they think the modifiable factor intervention would be and what the learning would be from this. And that's what we collect in the NCMD, and this is very unique data. And what we did is with the modifiable factors, there aren't specific data fields for poverty or social deprivation, but we've done qualitative analysis on this. So we've looked at all the free text data in the data submissions, and what we've done is to search for keywords. And the words that we used were poverty, deprivation, overcrowding, food bank, hardship, destitution, malnutrition, starvation, free school meals, working tax credit, universal credit, financial support, housing, accommodation issues, delays in benefits, homelessness, unemployment, debt, and vulnerability. And these words were used to search the database to identify all the deaths in which one or more of these keywords were mentioned. And the analysis of this it will be published in the report. So the recommendations from this report, there's only one recommendation really, and that is aimed at policymakers, public health services, service planners and commissioners at local and national level to engage with the data in this report and to develop and monitor the impact of future strategies to reduce social deprivation and inequalities. And what we foresee going forwards is that every year when we are publishing our annual report, there will be a section dedicated to impact of social deprivation. And that means going forwards, all agencies will be able to monitor the effect on child mortality, as a metric, as a very important metric going forwards. Once again, I'd just like to thank the partnership, and I'm very happy to take any questions. Here is just how to contact us. So if you're on Twitter, please follow at NCMD England. We have a website. To sign up to our newsletter, you can do that from the website, and to receive a copy of the report on child mortality and deprivation, you can also register on the website. Thank you, Matthew. I'm very happy to take questions.
Thank you very much, Karen. Whilst we're just waiting to see what comes in, obviously it's fair to say that social determinants of health are well recognised, and that it won't come as a surprise to this audience to hear that within a high income setting such as the UK, we see this play out just as we would see in a low and middle income country setting. But obviously with the report embargoed, we can't explore perhaps the exact correlations at the moment. But going ahead with these reviews, is there a way, do you think, of expanding the concept of modifiable factors to start thinking a bit more upstream about the social determinants?
Yes, I think that's what that was one of the findings from, analysing the data. This is the first year that we've actually have a full cohort of deaths for a year. And what struck us is when we wanted to ask, when we wanted to dig deeper into social determinants, it's the way the child mortality reviews are structured. They collect a lot of interesting data, and of course, a lot of it is qualitative data. But to actually work out whether, for instance, poverty may have contributed to a child's death is very difficult. So we had to use this free text qualitative analysis. So it would be really valuable for us to work with experts in the field to just think about, a set of questions that CDOPs can ask at the review that would cover these aspects. And of course, the challenge is always you can't ask 500 questions. So it's about asking, with brevity in mind, but asking the key questions. And of course, I mean, our country, we're very fortunate to have universal health care as well. So in a country like ours, you wouldn't really expect there to be massive differences in, for instance, the sort of things that are amenable to healthcare. So infections and areas of mortality like, babies dying due to asphyxia, for instance. These are things that you'd expect to be quite level across, all the deprivation deciles. From publications before this, we know that isn't the case. So there's a social gradient across many of these causes of death that actually, with universal healthcare, you shouldn't see.
So this methodology, which has grown out of work led in Bristol by Professor Fleming on sudden infant death, is likely to shed light on much wider issues as we look with this broader age range at the whole child cohort.
Yes, indeed. So I think infant mortality is relatively well studied in the UK, and certainly Public Health England have, 5 years ago they published a report on, and that was England and Wales, on the impact of social deprivation on infant mortality. But this hasn't been done before really for the older age groups above 1. And also not across the different categories of cause of death. So up to now, it's really just been focused on infant mortality, and particularly, as you say, on sudden unexpected death in infancy.
And Karen, I have a question from Professor Emond. Does the ranking position in Europe of the UK for under 5 mortality reflect the good quality data in the UK, or inequalities embedded in the UK?
Yeah, it's an interesting question. I think there are different views on this. Those that believe that we actually have reasonable mortality rates for, considering our income, would say that it's because we collect very good data on babies who are dying around the limits of viability. So that's the babies, around the 24-week gestation mark or just before. And that other countries perhaps don't do that. And so that means we're counting these babies in our numbers, and that's why our mortality rates appear higher. But having said that, in Western Europe, I think the majority of countries have quite good systems of assessing, counting mortality. The question is whether you actually whether you address the infants at the border of viability as stillbirths or as live births. So in this country, we tend to classify a baby if they're born with signs of life, irrespective of their gestation, they're classed as a live birth. And certainly that's how they go into the NCMD as well, whereas allegedly some other countries don't do that. They count those babies as stillbirths. Yeah, from this report, I think you could say that certainly in England, we certainly could reduce our child mortality rate even further, which would mean in Western Europe that we would be ranking with countries that are more in line with our financial income.
And it's certainly been a learning point through the pandemic, hasn't it, that the need for international standardization of collection methods on health metrics. And of course, conferences like this have been very influential in generalizing and extending the measurement of poverty. And I'm sure we in child health have work to do in generalizing some of this work on confidential inquiries into child deaths, which as you've highlighted this afternoon, can teach us a lot about the modifiable factors and help us to move things forward. So we're very, very grateful for your contribution today, Karen. And I'm afraid we do have to move on now to our next speaker. So thank you very much, Karen.
Thank you.